I know Becky wanted to come in with a quick question. Becky, over to you.
Yeah, thanks, Joe. It's very quick. Just to go back to financial sustainability, obviously, unlike local authorities, NHS trusts do run deficits. So where do you see those deficits going? And so how do you define sustainability with those deficits? Because obviously they vary across trusts. Where are you going to draw the line?
Yeah, so we want everybody to be in a balanced position at least.
So everybody in the black?
Medium term. Sorry?
Nobody running any deficits?
That's the intention. It's a long way from where we are now. And we've got, so we've had a lot of deficit support in the system. Recently, we're going to change a lot of the allocation methodology again to get back to allocating resources on the formula, but also expect every individual organisation over the medium term, the 3-year plan, to be back in a balanced position.
Sorry, just to be clear, in 3 years' time, no trust should be running a deficit?
That's the objective, yeah. It'll be very hard from where we are now, but that's the objective.
Thank you, Becky. Can we move swiftly on to Becky, please?
Thanks, Chair. Okay, so just to pick up a couple of things that I think you've touched on. Obviously, you've touched on a lot in this session. So the first thing is just to go back to redundancy, just be very clear about what you're able to say and put on record. So we did hear from local leaders that NHS England initially indicated there was a central pot of money to cover this cost.
We never said there was a central pot of money.
Okay,
We said we would.
Treasury later confirmed that didn't exist. So is that your understanding?
We said right at the beginning, which we were going to open a discussion and try and secure central funding.
How did the local leaders get this understanding? Where did that come from?
No, we never said there was a guaranteed central pot of money. It was always clear in the conversation that we're going to try and secure that, and we haven't yet managed to do that.
So do you think you might be able to do that?
I'm confident we'll find a solution.
Strikes like a true politician there. So.
across the spending review process.
Okay.
But honestly, we're in it. It's a very tricky process. We've been in it for a long time, and I really don't want to compromise it by saying too much today.
Okay, all right. But the ICBs can take some assurance to this, because obviously, as has been touched on, there are conversations about the ICBs paying for redundancies from local budgets, which has serious consequences. So they can take some assurance that there is light at the end of the tunnel, hopefully. So
as Glenn has already said, we had every of the new clusters, chief exec and chair of the new ICBs in a room, had this discussion last week. There's been also conversations, finance director to finance director. I think everybody should be crystal clear what we're trying to agree, what that will mean. There's a couple of different paths depending on different scenarios, and as soon as we have an answer, we'll mobilise that and it'll be executed.
Hopefully that's clear for the ICBs. Thank you. Just moving on to something else that I'm unclear about, which we've discussed with colleagues, is around ICBs and health and wellbeing boards. So prior to this government coming in and making these substantive changes, health and wellbeing boards and ICBs, in my own personal experience and other colleagues' experience, didn't always have the best of communications, the most transparent roles in terms of who did what and where the accountability was. So given that you said you are going to continue these two structures, where is the accountability going to lie? Are the health and wellbeing boards essentially reporting up to a regional structure, the old SHA, and ICBs together, who will be looking, I suppose, overall at what the ICB is doing and health and wellbeing boards? Because I do have serious concerns that it's not worked in the past.
I think this is one like the mayoral, where we need to come back with more clarification for you. The ICBs will report up to regions and the accountability will sit with regions. The Health and Wellbeing Board, their strength has always been their local democratic accountability. But one of the things in the 10-year plan that we talk about is that neighbourhood plans will come to the Health and Wellbeing Board for sign-off, as commissioning attentions did previously in the land of CCGs and also with ICB. So as an ICB and a CCG chief exec, I had to take my commissioning intentions for sign-off at the Health and Wellbeing Board.
But one other change linked to that within the 10-year plan was up until now, ICBs have had what's called ICPs, integrated care partnerships, and I think those partnership forums were slightly confused with the functioning of health and wellbeing boards. So we are saying the health and wellbeing board is where those partnership discussions take place.
So ICP is no longer.
Right.
Okay. All right. And so thinking about strategic commissioning then, which you've obviously referred to the fact that the ICB are going to become the strategic commissioners. I think my colleagues have mooted the fact of the strategic commissioning sits with the ICBs, but how does that marry with strategic commissioning of social care? And I appreciate the case review is underway, and strategic commissioning of public health, which is absolutely essential for the 10-year plan. How do you foresee the strategic commissioning across those three things working together, and where?
I mean, those still sit with local government colleagues, but I think that there are...
Not at regional authority level?
No. There are lots of other areas, though. So if we look at the need to improve prevention, then we need to look to the wider determinants of health. So we're always going to have this interface between public sector bodies to ensure that we use all those levers to improve the health of the nation. So that plays into education, it plays into employment and also sorts of other factors. So I think it's appropriate that does sit still within local government, and the NHS will always have to work really closely with them.
So again, just to be clear, between the ICBs, the health and wellbeing boards and strategic commissioning, for example, where is the Director of Public Health? The Director of Public Health remains in the unitary authority, presumably. Right. Okay. So when we're talking about strategic commissioning of public health, if we wanted to do it across a devolved region, that would amount to Directors of Public Health coming together, pooling their budgets. Is that how you envisage it working?
Yeah, I think what we're trying to explain is it'll have to work at lots of levels still. So every health body will have and as chief execs, we have a responsibility to collaborate and work closely with our local authority partners. Most of that is in place. The ICB will be covering more than one place, so they'll have commissioning responsibility across that bigger footprint. And where there's a combined authority, depending on how they're made up and what their interests are, there'll also be an alignment requirement of the NHS with those bodies. The reason there's lots of reasons why it's complicated, but not every combined authority is the same as well. Some have more of an interest in these things than others do. So the local arrangements are going to have to reflect that and make sure that there's appropriate alignment and engagement between health and the local authority system.
So forgive me, thinking about it from a population health point of view, when you are commissioning, and I understand an ICB and its strategic commissioning, I don't fully understand why you would not seek to align public health strategic commissioning with that. I'm failing to see that, because at a population health level, you're not looking at a smaller individual footprint. Why would you not seek to align those two things together?
So that is a core part of strategic commissioning.
But you're still keeping the public health commissioning function at a UA level?
It still stays within the local authority, yeah.
Because of the relationship into the wider determinants of health would be the argument for me. It's not just about what we do in the NHS.
Yeah, but arguably, if your 10-year plan is actually worth the paper it's written on, then you're moving from a treatment model to a prevention model, from a national sickness service to a national health service. Arguably, therefore, you're moving to a population health model. Therefore, I still don't understand why you're not looking at a strategic population health commissioning model that includes population health. Things like sexual health services, I fail to understand why we're still thinking about commissioning those within a local authority setting. I don't see the logic of it, I've got to be honest, apart from it got shifted during the Lansley shift and we're still there. Is there more logic that I'm missing?
Or just to say, are you still working through it?
Mm-hmm. Or let's be the chairs.
I think
just so that we don't go down.
Producing a 10-year health plan is a big job, first of all. We've had a lot to do to sort the NHS out. And colleagues have sort of touched on this today, without the NHS having clever views on what's done within local authorities and what their statutory responsibilities are. So what we're trying to do is emphasise all of these things have got to fit. We need to work with colleagues, but not fundamentally dismantle and tamper with local authority legal responsibilities and functions as well. I think it is possible to do what you've described with working with every local authority, and I think public health colleagues are actually very good at working together, especially on bigger strategic footprints. So I'm confident we'll be able to make this all aligned, and I'm also sort of trying to say we don't have to own everything for it to be better. So just a lot of this is about clearer operating model, devolution, having the right things done in the right place but through the right relationships. That doesn't mean ICBs have to have ownership of all of those things that we're talking about.
So, Sir Jim, once this is all sorted out, because at the moment it just seems that it's not quite there yet, are you prepared to come back to the committee and help us understand what you're trying to do? Because at the moment, Becky and a number of others have raised some very good points. And I feel, because my issue is, I don't know why you've moved things to the combined authority, that strategic authority, when everything you want to commission is lower down. So I'm struggling to understand myself. So what I would say, to just give you a get out of jail card, because these guys are good at what they do, would it be, just to help us move this on, that you come back to us when we're all clear on what it is we're doing, or you write to the committee?
Love to come back whenever you want me to.
Thank you. Becky, have you got any other questions?
So much.
Thank you.